This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, and welcome to the Neurology podcast. This is Dan Ackerman from St. Luke's Health Network in Bethlehem, Pennsylvania, and today I have the extreme pleasure of talking to Luciano Sposato, who is a professor of neurology and director of the stroke program at Western University in London, Ontario, Canada. Luciano, thank you so much for joining us today.
My pleasure. Thank you for having me.
So today we're here to talk about a really exciting paper titled Embolic Stroke of Undetermined Source, New Data and New Controversies on Cardiac Monitoring and Anticoagulation. This appeared online as of June 11th and in the July 9th print issue of the journal Neurology. Now, Luciano, this is a really interesting topic and one that we are continuing to try and figure out as we go. Since there's some variability in the terminology, could you just start by telling us what you and your colleagues are referring to as ESUS, and what is the real anticipated stroke reoccurrence for patients that are in that situation?
ESUS has three main components in its definition. The first one is that these are non-lacunar strokes based on brain imaging. So that's key because lacunar strokes would never be included in the ESUS definition. The second component is that there should not be intracranial or extracranial stenosis causing more than 50% narrowing of the arteries, right? At least in the territory that has been affected by the stroke. And the third component is that there should not be a high-risk cardioembolic source such as AFib or a mechanical valve or any other high-risk sources. For example, endocarditis, if you want to cite another one. So by having those three criteria, we can say that the stroke is an ESUS, but it's important to make clear how we work up these patients to be sure that they are ESUS. And that includes at least a 24-hour Holter to rule out atrial fibrillation, intracranial and extracranial vessel imaging to rule out carotid stenosis or any large vessel stenosis. And then, of course, brain imaging, either a CT or ideally an MRI to be sure that there are not multiple small strokes appearing as a lacunar stroke on a single CT scan.
All right, that makes a lot of sense. And what is the approximate reoccurrence rate for stroke in patients who have legitimate ESUS?
So this is a really important point because ESUS patients have the highest recurrence rates of all stroke patients. We can estimate it around 4 to 5%, both in patients that are treated with antiplatelet agents. There has been no significant difference in 4 randomized controlled trials of anticoagulants versus antiplatelet agents in terms of stroke recurrences. And that's why this is a topic that remains very important, both from a clinical and a research perspective, just because of the very high recurrence rate.
It sounds like when we define ESUS, we're not only talking about appearance on MRI imaging, but you really have to take a holistic view of looking at the patient's risk factors, their vasculature, really try and put the whole picture together before we label this as ESUS. But when we do that, I understand why we try and be reasonably aggressive with secondary stroke prevention, given that high risk. What's the source of the controversy then? When we talk about secondary stroke prevention for these folks, why is it so difficult?
This paper, or the definition of ESUS, was published in a landmark Lancet Neurology paper. And I think the authors were preparing for the 2 ESUS trials, the first 2 ESUS trials, Respect and Navigate ESUS, in which they needed a fairly straightforward definition so that they can ensure the recruitment of the patients needed for these large randomized controlled trials, right? For example, they only required 24 hours of Holter monitoring, as I said before. And now we know very clearly that with 24-hour Holters, we will leave a very large proportion of patients with subclinical AFib or with asymptomatic AFib without being diagnosed. And that's a big problem, right? Because we know from studies of implantable loop recorders that we can detect up to 25% of cases with atrial fibrillation after 1 to 3 years of cardiac monitoring. That's a whole different topic, what to do with those patients. But what I can tell you is that there is a huge proportion of cases of AFib missed if we only use 24 hours. That's the problem number one. The second problem is that also, as I said before, this paper was published in 2014, 3 years before the PFO trials were published in 2017, in which there was a clear benefit for PFO closure over antithrombotic therapy for preventing recurrent strokes in young patients with a PFO. If we look at the definition of ESUS, the classical one, patients with PFO were still included in the group of ESUS patients. Now we know that if they're younger than 60 and if they have a high-risk PFO defined as a large PFO with more than 20 to 30 bubbles on echocardiography, or if they have a mobile or aneurysmal interatrial septum, those patients are high risk and would benefit from closure. So again, that's a small problem of the ESUS definition. We just need to leave those PFO patients out. And then the other issue is that it is a very heterogeneous group of patients. We have some people with ESUS that have other underlying etiologies, such as aortic plaque or carotid artery disease or cancer-related hypercoagulability, which are less likely to benefit from anticoagulants or at least classical oral anticoagulation. So those are the problems that arise after the definition. And I think there are a couple of take-home messages that we can highlight for clinicians. The first one, and from a clinical perspective, is that it is still a very useful classification because it helps clinicians organize their minds or their workup when they are trying to identify the etiology of the stroke. And then from a research perspective, it is still very useful to keep this definition because this is a very high-risk population. And we should not neglect the ESUS concept just because 4 clinical trials showed no benefit, right? Instead of doing that, we need to keep trying, keep to refine the population that is more likely to benefit, as it will be done in the MOSES trial, which is an ongoing clinical trial comparing anticoagulants against antiplatelet therapy, in which patients are being selected in a better way, or a more efficient way, I think. They are using ANP instead of BNP, which has been shown to be released by the left atrium. It's a predictor of AFib, and it's a predictor of major adverse cardiovascular events. MOSES is using a validated threshold for ANP instead of using other markers that were used in Arcadia, such as P-wave terminal force in V1, or a cutoff size for the left atrium that was not really very common. So it was I would say, a very selective type of threshold for the left atrial appendage. So maybe another trial with a better patient selection will show positive results. And that's why I think we should keep trying from a research perspective.
So that makes a lot of sense, but there's a lot to unpack there. Let me maybe try and summarize that just a little bit. I think part of the controversy with ESUS, first of all, is that it's a moving target. What was considered ESUS, for example, before the PFO trials might not be considered ESUS now. And it centers around the presumption that patients with central embolic strokes may do better with oral anticoagulation, and particularly those with previously undiagnosed atrial fibrillation. But when we look at all of these other potential causes for central embolic stroke that may not be as amenable, or for patients with no easily identified cause, we're still trying to figure out who the target population really is that will benefit based on our initial stroke evaluation and looking at all their risk factors. So even though ESUS is a controversial concept and is a moving target, it sounds like we're still doing new trials, still working to refine the definition and make it very clinically relevant. Is that about right?
Exactly. That's a great summary, Dan.
I really loved this review. I think it was a great refresher on some things. I liked the approach that you guys took. Could you summarize for us, what did you find in your review and what's the new information that might help inform our practice?
I think there are 2 main topics. The first one is the publication of recent ESUS trials, 4 randomized controlled trials, which did not show a benefit for anticoagulants over antiplatelet agents. And I think the second one that we have been waiting for a long time is a publication of 2 RCTs on subclinical atrial fibrillation. This is AFib that has never caused any symptoms, but it's still there and found on implantable loop recorders or other implantable devices. So these 2 trials have been ongoing for 4 to 5 years and were both published in 2023. And I think we should just focus now on the concept of subclinical atrial fibrillation, which is how we call them in North America, or atrial high rate episodes, which is the way it is called in Europe. So they both mean the same. They are short-lasting episodes of atrial tachyarrhythmias, for which we know that there is an elevated stroke risk compared to the population who does not have SCAF or AHREs. So these 2 trials were NOAA AFNet 6 and Artesia. And the interesting thing about them is that they showed different results. The first one to be published was NOAA, and it showed that it actually was stopped because of concerns about major bleeding after our DSMB review of the results. And then by the time it was stopped, they found that there was no benefit for anticoagulants compared to antiplatelet therapy, but it might be just because the sample size was lower than the estimated number of patients that they needed for the power calculation. So at that time, those studies showed, or at least were in line or consistent with what we were thinking, that they will show that no benefit because overall these are low-risk patients just because they are asymptomatic and they have a device-detected AFib instead of being an ECG-detected AFib. But then in November 2023, the Artesia trial was presented at the scientific sessions and then published in the New England Journal of Medicine, and it showed that there was a slightly lower risk of stroke or systemic embolism in patients receiving apixaban compared to those receiving aspirin if needed, or placebo if they didn't need aspirin. And overall, the other side of the coin was that patients receiving anticoagulants had a higher risk of major bleeding. In those who actually received the drug, the risk of major bleeding was 80% higher. So there's a little bit of controversy in terms of why one study was positive, the other one was negative, and why one study was stopped and the other one was not stopped because of concerns of major bleeding. One of the main differences between both studies is that the primary outcome of NOAA was stroke, systemic embolism, and cardiovascular death, whereas in Artesia, the primary outcome was stroke or systemic embolism. And that might be one of the main reasons why there were some differences. But there are other factors to consider. So I think these two studies are important for the stroke community. The Artesia trial had the sub-analysis on patients with prior stroke or TIA presented at the European Stroke Conference this year. And they suggested that the risk of stroke recurrence was higher in that population, of course, compared to those who did not have a prior stroke. And the benefit was even larger, but those results have not been published yet. And as far as I know, the sub-analysis on patients with stroke and TIA of the NOAA trial will be published very soon. And hopefully we will be able to see those results by the time the podcast is published or uploaded.
I feel like we're frequently waiting for that. What's the subgroup and how do we apply it? But that's actually really exciting and interesting. And rather than the negative trial suggesting that there is not a benefit to defining ESUS or defining patients as having experienced an ESUS event, I think it really pushes us towards exactly what you're describing, the need to better define which patients are high risk, which patients are low risk, try and stratify people so that we can figure out what the stroke pathophysiology really is and in what way we can prevent it from happening again, right? That's really the bottom line. It's all about that secondary prevention.
Exactly.
A lot of times in the past, we've used AFib as a qualitative yes or no. You either have it or you don't. And of course, in our stroke world, if you've got it, you're likely supposed to be on some sort of a thinner. Whereas in the cardiology world, where they see everybody and a lot of people with lower CHA2DS2 VASC scores, in your paper, you posed an interesting question about that. How do recent randomized controlled trials testing the efficacy and safety of anticoagulation in device-detected AFib and high-risk populations affect the current landscape of secondary stroke prevention? Now, you described this a little bit, but just to get into that further, when we talk about device-detected AFib, are we only referring to implantable loop recorders, or is this any device-detected AFib? And how do you think it should change what we do after the initial adjustments we made with those 4 negative randomized trials?
We need to see this as a continuum of atrial fibrillation burden. AFib burden means how much or how long AFib lasts when it's being monitored in relation to the duration of monitoring. If we find AFib in someone who has symptoms like shortness of breath or, palpitations, and comes to emerge and we do an ECG and we find AFib, a 12-lead ECG, and we find AFib, that's a very high-risk patient. Why? Because that person had symptoms, number one. And number two, if we find AFib on a 12-lead ECG, it means that the AFib burden is more than 24 hours in a loop recorder. So the duration of AFib is crucial in that sense, and ECG-detected AFib is very high risk. If we move to the other end of the spectrum and we look at implantable loop recorders, we can see that sometimes after monitoring a patient for 3 years or so, we find a very short burst of AFib, not related to the time of the stroke onset, but perhaps 1 or 2 years later, and then it never appears again. It never happens again. That's a very incidental, short burst, low burden, non-related episode of atrial fibrillation, which means that it's very likely low risk. And in general, those episodes, we see them in patients with no structural heart disease, meaning that they don't have a dilated left atrium, a lower prevalence of risk factors, and things like that. So those are low risk. In the middle, we can see patients with 24 or 48 hours of Holter monitoring, in whom we find AFib, and those might be an intermediate risk patients. And then if we look at 14-day Holters or 30-day Holters and we find AFib, it'll depend on how long that AFib lasts. So something that it's important to note is that in both NOAA and Artesia trials, they used implantable cardiac devices, meaning that they used pacemakers, defibrillators, implantable cardiac monitors, right? So those are very long periods of monitoring, and sometimes the burden of AFib is pretty low in those patients. That's the number one point that we need to highlight. The second point is that these patients, because they were using those devices, are different from those who have strokes, who are the patients that we see on a regular basis. These are patients with more heart disease probably that led those patients to require a heart monitor or a device. The second and very important point is that the recurrence rate of these patients is around 1% per year. Remember what we said about ESAs, it's around 4% per year. So it's 4 times higher, meaning that this is overall a low-risk population. And the expected benefit of using anticoagulants will be, in absolute terms, lower than for patients with ESAs. For example, if we look at the Averroes trial, in which they compared anticoagulants against aspirin in patients with AFib, that was in most of the cases symptomatic and ECG detected, the absolute benefit was around 2%, 1.9%. If we look at the absolute benefit in Arcadia and NOAA, it's around 0.4%. So the benefit was 5-fold higher in patients from Averroes compared to those from Artesia or NOAA. Again, it was a positive study, but the absolute benefit is low. It's pretty low. And then, of course, we need to consider that the risk of major bleeding in those trials was still high. So the take-home message in terms of this point is that we need to advocate for a more personalized approach, and we should not use a one-size-fits-all approach of giving anticoagulants to everyone. And if you look at the recent literature, you will see that there are lots of editorials or comments in different cardiology or neurology journals suggesting that we need to be very careful in the way we use the data from Artesia. We need to be smart, and we need to be able to personalize our decision-making process.
Absolutely. Treating each patient as an individual and understanding their personal risk factors. And I really like bringing in some of these other aspects of a patient's cardiac health, looking at AFib not only as an arrhythmia, but understanding it in the background of other types of heart disease, left atriopathy and left atrial dilation really can make a big difference as we're trying to figure out who is high risk and who is low risk. Where is the benefit going to outweigh the risk when we're talking about anticoagulants, and particularly for patients who have other types of vascular disease, be it coronary artery disease or carotid disease, peripheral artery disease, where we start talking about combining antiplatelet regimens with anticoagulant regimens and the like, because that discussion can get awfully complicated awfully fast.
Absolutely. I think you raised a very important point. For example, we have someone, if you look at the Stroke AF trial, right? They looked for AFib with implantable loop recorders in patients with large artery disease or small vessel disease strokes. They have a clear cause. They have a clear treatment for preventing strokes, which is antiplatelet agents and statins. And we find AFib. So what do we do with those patients? We need to use anticoagulants and antiplatelet agents. We don't know. If we just opt for a direct oral anticoagulant, we will not be treating the cause of their stroke, which is small or large vessel disease. And that generates a problem. If we use both, we will be increasing the risk of intracranial hemorrhage by 37% just by adding aspirin to apixaban, for example, as the Aristotle trial showed. I think we need to be very selective in the way we screen for AFib and in the way we approach treatment decisions.
Your paper includes some great practice considerations. I loved the figure. It was titled Dynamic Risk Stratification. That was great. So just to wrap us up, can you tell us a little bit about those considerations and how we can take this paper and practically apply it to what we're doing in stroke practice from day to day?
Dynamic risk stratification means that we need to use everything that is available right now to help our decision-making process. For example, we know that biomarkers such as BNP or sometimes troponin or ANP or other newer biomarkers are helpful for predicting who's going to have a recurrent stroke or who's going to have AFib detected. So we should try to use biomarkers. We know that patients who are not adherent to direct or anticoagulant treatment have a higher risk of stroke, right? So we know that fever or an infection can lower the threshold for someone to experience a stroke. There are lots of parameters that can be monitored on real-time basis just by using multi-parametric monitor or a recorder. And what we are imagining is something like an external or an implantable device that can measure body temperature, sleep quality, levels on a periodic basis, AFib detection, AFib burden, inflammatory markers. I know it sounds like science fiction, but we are planning on sending humans to Mars as a second planet to live on. So I don't think it would be too difficult to do this. And if you dig it a little bit into the web, you will see that there are students in many countries in the world working on projects like this. And I'm saying students, high school students, not scientifics, right? So I think we are all living in a new age. AI-driven analysis in real time of all those parameters will allow us to predict when someone is going to be at a higher risk of experiencing a stroke. And maybe we can adopt a pill-in-the-pocket approach in which we will tell patients to take some extra medicines or avoid doing certain things to prevent their strokes. We know that if someone has severe triple vessel coronary artery disease, symptomatic with small efforts, that person will not go out in the winter to get rid of the snow in their driveway. So those are things that are very clear for myocardial infarction, but they're not that clear for strokes. So the dynamic risk stratification model means that with devices, we will hopefully be able to predict who's going to have a stroke in the short term and act in consequence to prevent those strokes.
I love it. So yeah, we're going to have to stay on our toes as we get more into wearables, as AI gets more and more into what we're doing. Ultimately, though, this really requires clinical understanding, and it's going to require ongoing interpretation by stroke neurologists. And because the treatment of stroke, and particularly patients like this, is going to continue to get more and more nuanced, it's something that we can expect to probably become a little more complex before it becomes less complex. But hopefully that's because we're moving towards individualized and tailored care for each patient. Luciano, thank you so much for joining us today. It's been really such an enjoyable discussion. I would encourage all of our readers to check out the full article titled Embolic Stroke of Undetermined Source, New Data and New Controversies on Cardiac Monitoring and Anticoagulation. That can be found online or in the July 9th printed issue of the journal Neurology. Luciano, thank you so much again.
My pleasure. Thank you.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes, or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.